So good evening everyone. Am I audible to all? Yes. Good evening. So very good evening. I am Dr. Rahul Nikumbhe, MD Medicine faculty at DAMS, and today we are going to discuss very important MCQ for your exam. Okay. So can we start? All of you are there? Okay. So let us start with our first MCQ. So we are having only 1 hour of discussions. So let us start without wasting our time. So first MCQ: a 35-year-old female presented with 1 year history of menstrual irregularity and galactorrhea. Galactorrhea means abnormal milk discharge not associated with childbirth. She also had off on and off headache. Headache is also there, and her examination revealed bitemporal hemianopia. So one visual field defect, headache, menstrual irregularity, and galactorrhea. Which of the following is the most likely diagnosis in this case? Okay. So what is your answer for this? Option A, pituitary adenoma secreting growth hormone, prolactinoma. Option C, Cushing disease, pituitary apoplexy. Yes, dear students, what is your answer for this? So, female patient having menstrual irregularity, galactorrhea, headache, bitemporal hemianopia. Now, if I discuss options, the first option is pituitary adenoma secreting growth hormone. Now, this adenoma, tumor of pituitary, it can compress optic chiasma. If optic chiasma is compressed, then patient will have visual field defect, and the classical visual field defect after compression of optic chiasma is bitemporal hemianopia. So bitemporal hemianopia can occur, but if growth hormone level increases, it cannot cause menstrual irregularity, it cannot cause galactorrhea. So growth hormone is not responsible for this. So option A, it is not the correct answer. Prolactinoma, that is the tumor of pituitary secreting lot of prolactin. Prolactin is secreted by lactotrop cells. If pituitary is having a tumor of lactotrop cells and this tumor is secreting lot of prolactin, now this increased prolactin, it inhibits ovulation, it inhibits folliculogenesis, and it causes amenorrhea. Plus, prolactin is required for development of lactating glands in pregnancy. So this prolactin stimulates lactating glands, so it can cause galactorrhea. So menstrual irregularity and galactorrhea can be caused because of increasing prolactin. Next, if prolactinoma, if size of the tumor is more than 1 centimeter, It is called as macroadenoma, and this tumor, it can compress optic chiasma. So this patient of prolactinoma, he will also produce visual field defect. He will also have bad temporal hemianopia. So prolactinoma, it is the correct answer. What is Cushing disease? Cushing disease, it is a Cushing syndrome because of tumor of pituitary. So pituitary tumor secreting lot of ACTH, adrenocorticotropic hormone. It is called as Cushing disease. So if patient is having a tumor of pituitary secreting lot of ACTH, then this ACTH will stimulate adrenal gland and cortisol secretion will increase. Increase in cortisol, this patient will have clinical feature of central obesity, moon-shaped face, buffalo hump. So these are the clinical features of Cushing syndrome or Cushing disease. Here our patient is not having clinical features of Cushing syndrome. So it is not a case of Cushing disease. What is pituitary apoplexy? In pituitary apoplexy, there is intrapituitary hemorrhage, sudden rupture of blood vessel in pituitary or sudden infarct of pituitary. It will cause severe damage to pituitary. Actually, it is acute case and it is endocrine emergency. Patient will have hypotension, hypoglycemia, severe headache, bitemporal hemianopia can occur. Okay, but presentation will be acute. Clinical features will be hypotension, hypoglycemia, headache, and visual field defect and cranial nerve palsy. Clinical features of increased intracranial pressure. Okay, so it is not a case of pituitary apoplexy. So correct answer is prolactinoma. Next, confirmatory investigation for acromegaly is. Now what is acromegaly? It is hypersecretion of growth hormone. So suppose patient is having tumor of pituitary. This tumor of pituitary is secreting lot of growth hormone. Okay, so it is acromegaly. Now what is the confirmatory test to prove that patient is having acromegaly? Insulin induced hypoglycemia? No. When I am suspecting growth hormone deficiency, if I am suspecting pituitary is not able to secrete growth hormone, then investigation will be insulin induced hypoglycemia. Suppose suppose if pituitary is having infarct or damage, hemorrhage, and pituitary is having some infection, pituitary is not able to secrete growth hormone, then I want to stimulate pituitary to secrete growth hormone. How will you stimulate pituitary to secrete growth hormone? Normally, growth hormone stimulate, normally growth hormone increases gluconeogenesis, glycogenolysis. So normally growth hormone increases glucose. Suppose in a normal person, if I give insulin, then this insulin it will decrease glucose, and this decreased glucose it will stimulate pituitary, normal pituitary, to secrete growth hormone, and growth hormone level will increase. So if I give insulin, after giving insulin I will measure growth hormone level in blood. After giving insulin, if growth hormone level increases in blood, it means pituitary is responding, pituitary is normal, pituitary can secrete growth hormone. But if I'm suspecting acromegaly, then I'm suspecting a tumor which is secreting lot of growth hormone. And whenever tumor cells are present, tumor cells they secrete hormone independent of everything. Simply, you are not able to inhibit the tumor secretion of hormones. So now what I will do, I will try to inhibit the cells. So how will you inhibit? Suppose if I increase glucose level in blood, if I increase glucose level in blood in a normal person, increase glucose in blood, it will inhibit normal pituitary. and it will decrease growth hormone secretion. So I will cause hyperglycemia. How will you cause hyperglycemia? I will give oral glucose. I will give 75 gram of glucose orally. It will increase glucose level in blood. It will give feedback to pituitary. Now after giving glucose, I will collect the blood sample. I will measure growth hormone level. After giving glucose, after causing hyperglycemia, I will measure serum growth hormone level. If serum growth hormone level is decreased, it means I am able to inhibit pituitary. It means pituitary cells are normal. They are responding to hyperglycemia because they are inhibited by hyperglycemia. But suppose after giving glucose, after causing hyperglycemia, I have collected the blood and I am getting high level of growth hormone. Means I am not able to inhibit cells. Cells are not inhibited. It means hyperglycemia is not able to suppress cells. It means these cells are not normal. They are tumor cells. They are tumor cells. So it will confirm your patient is having tumor of pituitary secreting lot of growth hormone. So answer is glucose induced growth hormone suppression. It is also called as oral glucose load test. It is also called as oral glucose load test. Random growth hormone assay, it is not having any importance because normally growth hormone is secreted in a pulsatile manner. In a normal person, growth hormone secretion suddenly increases, suddenly decreases. So in a normal person, you may get a very low level of growth hormone. Okay, so if growth hormone level is low, it doesn't mean that your patient is having growth hormone deficiency. But if after stimulating pituitary growth hormone level is low, then you can say your patient is having growth hormone deficiency. Pituitary is not able to secrete growth hormone even after stimulation. IGF-1 level. If growth hormone level increases, IGF-1 level will increase. Okay, but this test is not confirmatory. IGF-1 level, it is a screening test. In exam, in this question, they have asked confirmatory test. Confirmatory test is glucose induced GS suppression. So same MCQ, if they ask you what is the screening test, what is the screening test for acromegaly, answer will become IGF-1 level. If they ask you confirmatory test, answer will become glucose induced GS suppression. Next, Cone syndrome is associated with all except. Okay, so please, whenever you read MCQ and you are having a word except, so be careful, take a pause, think about all options and then answer. So in this, first you should know what is meaning of Cone syndrome. You should know what is meaning of Cone syndrome. Cone syndrome means adrenal adenoma secreting lot of aldosterone. Now all of you know that adrenal gland secretes aldosterone. Suppose this adrenal gland is having a tumor. Tumor means abnormal cells, tumor cells, cancer cells. They are secreting lot of aldosterone. And tumor cells, they always secrete hormone independent of everything. So now this aldosterone secretion will increase, and normally aldosterone normal action is increase absorption of sodium plus water. So absorption of sodium plus water will increase. When sodium plus water absorption increases from kidney, intravascular fluids will increase. When intravascular fluid increases, it will cause hypertension. So hypertension occurs in Cone syndrome. Now, when sodium is absorbed, there will be loss of other positive charge. one positive charge is absorbed, so in exchange kidney will lose potassium, so there will be loss of potassium, so patient will develop hypokalemia. So hypokalemia can occur. This hypokalemia, it can cause paralysis, weakness will occur. So hypertension, muscle weakness, hypokalemia, it will occur in Cohen's syndrome. Okay, but remember, edema is absent in Cohen's syndrome. Edema is not a clinical feature of Cohen's syndrome. Now, why edema is absent? It is not given in our standard textbook Harrison. It is the sentence from Harrison. Edema is absent in Cohen's syndrome. Generally, it is absent. Now, why it is absent? Lot of theories are proposed. I will tell you a simplest theory to understand this. This tumor is secreting lot of aldosterone. Okay, now this aldosterone, it will reabsorb lot of sodium plus water, so increase intravascular fluid will occur. Intravascular fluids which are increased, they will go towards heart. Okay, and now lot of fluids are coming towards heart, so workload on heart will increase, and whenever workload on heart increases, heart releases natriuretic peptides. There are two natriuretic peptides released by heart: atrial natriuretic peptides called as ANP, and brain natriuretic peptides called as BNP. Atrial natriuretic peptides and brain natriuretic peptides. Now see, name is brain, but these peptides, they are not released by brain. Name is brain, but these peptides, they are not released by brain. These peptides, they are released by ventricles of heart. Please remember this. Atrial natriuretic peptides, they are released by atria of heart. Brain natriuretic peptides, they are released by ventricles of heart. And these natriuretic peptides, they cause loss of sodium plus water. So on one side, aldosterone is absorbing sodium plus water, and on one side, heart is trying to compensate this absorption by loss of sodium plus water. This loss of sodium plus water because of natriuretic peptide, it will prevent edema formation. It is just a proposed mechanism. Okay, so Cohen's syndrome, hypertension, muscle weakness, hypokalemia, these are the clinical features. Edema is not the clinical feature of Cohen's syndrome. Next, inappropriate ADH secretion is characterized by following: except, again the word except is there. Inappropriate ADH secretion, it means syndrome of inappropriate ADH secretion, SIADHCR. Now, what is ADH, inappropriate ADH secretion? For your exam, remember I for inappropriate, I for increase ADH. So in SIADH, ADH level increases, increase secretion of ADH. What is the function of ADH? ADH reabsorb the water. Only water will be absorbed from the tubules of the kidney, and this water will be added to serum. Suppose this is a nephron, proximal convoluted tubule, loop of Henle, distal part of nephron, okay, collecting ducts, okay, and suppose this is a blood vessel, or you can say serum or blood vessel, and these are the principal cells of distal part of nephron which are having V2 receptors, If ADH is present, ADH present in blood, it will act on V2 receptors. Okay. Now, what is happening? serum or blood, it will enter in nephron. Okay, this blood, it is having lot of water molecules, and these water molecules, they will enter in nephron. These water molecules, they will enter in distal part, and if ADH is present in blood, if ADH, if it is present in blood, ADH will act on V2 receptors. When ADH act on V2 receptors, there are formation of aquaporin channels. There are formation of aquaporin channels, and now these aquaporin channels, they will reabsorb the water molecules, and now these water molecules, they will be added to serum. If ADH is absent, V2 receptors will not be stimulated, and these water molecules, they will be lost in urine. This is urine. So what is the function of ADH? ADH absorbs the water from the tubules of the kidney, and water is added to serum. So when ADH increases, water is absorbed from the urine. So water is absorbed from the urine, water will decrease from the urine, urine will become concentrated, that is, urine will become hyperosmolar. What is the first option? Hypoosmolar. So it is not possible, it is not happening in SIDH. Water intoxication, yes, it will occur. Lot of water is absorbed, it is added to serum, so water intoxication will occur. Expanded fluid volume, yes, intravascular fluid will increase, and only water is absorbed, so serum will be diluted. So serum, sodium, potassium, magnesium, everything will be diluted, so patient will develop hypomagnesemia. So BCD, all these three are possible, but hypoosmolar urine, it is not possible. It should be hyperosmolar urine. So fourth one, answer is A. Now next one, which of the following findings can establish a diagnosis of diabetes mellitus? A very simple MCQ. You should know the correct criteria for diagnosis of diabetes. Okay. So first I will show you the criteria. This is the diagnostic criteria of diabetes in Harrison, from Harrison. When will you say your patient is having diabetes mellitus? If your patient is having symptoms of diabetes, what are the symptoms of diabetes? Polyuria, polydipsia, polyphagia, and weight loss. If patient is having symptoms of diabetes plus random blood sugar, that is sugar level more than 200 milligram per dl. Okay, so the patient is coming to you in OPD, patient is telling you he is having polyuria, polydipsia, polyphagia, and weight loss. You will check the sugar randomly. If sugar level is more than 200 milligram per dl, your patient is a case of diabetes. Next, fasting blood sugar level, FPG, fasting plasma glucose. If it is more than 126 milligram per dl. Now fasting for how many hours is required? 8 hours. So at least 8-hour fasting is required. Patient will come to you with 8-hour fasting. You will collect the blood, that is fasting glucose. If it is more than 126, your patient is a case of diabetes. Then 2-hour plasma glucose. In oral glucose tolerance test, patient will come to you in a fasting state. You will collect the sugar, it is fasting sugar. Then you will give 75 gram of anhydrous glucose to your patient. Patient will drink the solution of 75 gram of anhydrous glucose. After this, you will not allow your patient to eat or drink anything for 2 hours. After 2 hours, you will collect the blood and you will check the sugar. It is postprandial blood sugar or it is 2-hour plasma glucose. If it is more than 200 milligram per dl, your patient is a case of diabetes. Or if HbA1c, if it is more than 6.5%, it is a case of diabetes. So if any one out of these four is positive, if any one out of these four things they are present, Your patient is a case of diabetes. Okay, so answer is D, HbA1c more than 6.5. Fasting, it should be 126. Fasting, it should be 126. 2-hour plasma more than 200. Fasting 126, 2-hour plasma more than 200. Symptoms of diabetes plus RBS more than 200. So all ABC are wrong answers. Lab values in a patient with diabetic ketoacidosis includes decrease anion gap. No. In diabetic ketoacidosis, anion gap increases. What is anion gap? Anion gap is equal to sodium concentration minus chloride plus HCO3 minus. In diabetic ketoacidosis, ketones are formed. Ketones are donating H plus ion. These H plus ions from ketones, they will combine with bicarb. They will form H2CO3. So in blood, HCO3 minus will decrease. So anion gap will increase. So it is not the correct answer. Increase sodium levels? No. Whenever glucose level increases in blood, sodium level decreases in blood. Serum glucose and serum sodium, it is inversely proportional. It is the sentence from Harrison. When serum glucose increases by 100 milligram per dl, serum sodium will decrease by 1.6 milli equivalent per liter. Okay, so in diabetic ketoacidosis, glucose level increases, so sodium level should decrease. Okay, next, increase potassium. Yes, potassium level will increase. What is happening in acidosis? H plus ions are increasing in blood. Now these H plus ions, they will enter in cells. Our cells, they are having lot of potassium, so H plus will enter in cell, and in exchange potassium from cell, it will enter in blood, and patient will have hyperkalemia. So increase potassium. Increase arterial CO2. No, again it is a wrong answer. In our patient of diabetic ketoacidosis, what happens? Ketones will donate H plus ions. H plus ions will combine with HCO3 minus. It will form H2CO3. H2CO3, it will be broken down into H2O and CO2. Now this CO2 in blood, it will stimulate respiratory center, and when respiratory center is stimulated, respiratory rate will increase. Patient will have hyperventilation. It is called as Kussmaul's breathing, a characteristic type of breathing. And because of hyperventilation, it will cause washout of carbon dioxide. And because of washout of carbon dioxide level will decrease in blood. So correct answer is C. Read the next MCQ. Which of the following is true regarding HBeAg in serum? Envelope antigen. It signals recovery from HB infection. No. Indicates viral replication and infectivity. Yes. If envelope antigen is present, it means virus is replicating and patient is with high infectivity. So if envelope antigen is there, virus is replicating. So answer B is correct. And evidence for successful vaccination against hepatitis B? No. If your patient is having only anti-HBs antibody positive, then you can say your patient is vaccinated. Enhances the severity of HBV and increases the risk of cirrhosis? No, it is not associated with severity of the virus. It is not associated with cirrhosis of liver. Next, a 30-year-old man presented with nausea, fever, jaundice. Jaundice is there, fever is there. Jaundice means suggestive of liver problem or maybe hemolysis. Fever suggestive of infection. 5 days duration suggestive of acute infection. of the biochemical test revealed bilirubin 6.7, total is 6.7, conjugated 5, AST 900, ALT 1400, AST ALT normal levels are between 10 to 40, both levels are increased. Serological test showed presence of surface antigen. If surface antigen present, infection is present. So infection is there. IgM anti-HBC suggestive of acute infection is there. Envelope antigen is present. It means virus is replicating. Patient is with high infectivity. So my diagnosis acute viral hepatitis B with high infectivity. So see, acute hepatitis infection with high infectivity. Why not chronic? In chronic, surface antigen will be present with IgG anti-HBC. Okay, chronic hepatitis is not the correct one. Acute hepatitis with low infectivity. Why not D? Because if infectivity is low, then envelope antigen will be absent, anti-HBe antibody will be present. So I can rule out all these options. Correct answer is option B. Which of the following is not a feature of primary sclerosing cholangitis? Primary sclerosing cholangitis. Okay. It is more common in male. Yes, it is more common in male. Pruritus is a clinical feature. Yes, pruritus is a clinical feature. It is associated with ulcerative colitis. Yes, around 50% patients of primary sclerosing cholangitis, they have ulcerative colitis. So colonoscopy should be done. Liver biopsy is diagnostic? No, liver biopsy is not diagnostic. Why? In primary sclerosing cholangitis, what is happening? There is damage to intrahepatic bile ducts and extrahepatic bile ducts. So intrahepatic and extrahepatic bile ducts are damaged. Cause is not known. We don't know the cause, why it is happening, but something is damaging the bile ducts in the liver, outside the liver. So there is inflammation, fibrosis of bile ducts. So if I want to confirm the diagnosis, I want to scan whole biliary duct system. If I do liver biopsy, then I can comment only about intrahepatic ducts. I cannot comment about extrahepatic duct. So liver biopsy is not diagnostic. So what is diagnostic? ERCP, MRCP. These are the diagnostic tests for primary sclerosing cholangitis. All of the following are characteristic neurologic manifestations of Wilson's disease except, again the word except is there, dystonia. What is happening in Wilson's disease? In Wilson's disease, serum copper is increasing. Now, this increasing serum copper, it will be deposited on multiple organs. When this serum copper is deposited on basal ganglia, patient will have dystonia or Parkinsonian features. Then multiple organs will be affected. Autonomic nerves, sensory nerves, motor nerves, multiple parts in brain will be affected. When autonomic nerves are affected, sexual dysfunction will occur. Cognition, it is the sentence from Harrison. Cognition can be impaired, but it is not severely impaired. So it is the correct answer. Dysphagia can occur because this serum copper, it will be deposited on cranial nerves. When it gets deposited on cranial nerves 9, 10, 11, patient will have dysphagia. So A, B and D, they are the severe features, but C, it is not severe. Cognition can be impaired, but it is not severely impaired. A 40-year-old male known case of cirrhosis of liver develops acute episode of GI bleed, hematomasis or melena. Initial therapy given for 6 hours. Sorry. What is initial therapy? You will give the drug octreotide, terlipressin, IV fluid, blood transfusion. So you will try to stabilize the patient. Which of the following procedure is useful now? In this patient, the first line treatment of choice is endoscopy. In endoscopy, you will take the endoscope, you will enter in esophagus, You will search for esophageal varices. If varices are present, you will do endoscopic variceal band ligation. Next, read the next MCQ. All of the following are features of absent seizure except, again the word except is there. Usually seen in childhood, yes, usually seen age group 5 to 15 years. It is the common age group. 3 herb spike wave in EEG, yes, it is also correct answer. Characteristic feature is 3 hertz spike and wave in EEG. In electroencephalogram, you will get a characteristic spike wave, spike wave, spike wave. This is the characteristic pattern. Post-ictal confusion. Post-ictal confusion, it is not the feature of absent seizure. Post-ictal confusion is absent in absent seizure. Precipitation by ventilation, yes, hyperventilation precipitate EEG changes, or you can say seizure. Okay, so now we will discuss the important points of absent seizure. Now, what is actually absent seizure? Suppose there is a child of around age group 5 to 15 years. Okay, we are discussing typical absent seizure. And suppose this child is having food, he is eating food, and suddenly seizure comes. What will happen? Patient will stop. That child will stop for around 10 to 15 seconds. During this time, that child is unresponsive. If you call that child, he will not give any response. There is no abnormal jerky movements, no loss of tone. Okay, just there is a pause for 10 to 15 seconds. After 10 to 15 seconds, again that child, he will resume his activity as he was doing before. So patient is having sudden brief lapse of consciousness without loss of postural control, without any abnormal jerky movement. Okay, and these patients generally they are children, and parents, they will come to you with the clinical with complaints like decreased school performance. These students, they are not able to concentrate during class. That teacher is not able to recognize that it is a seizure because patient is not having any abnormal activity. Okay, and most of the teachers or parents, they think that that child is daydreaming. They think सपने देख रहा है, ये जस्ट वो देख रहा है, सपने देखता है, वापस नॉर्मल हो जाता है. इट इज अ टाइप ऑफ सीजर. ओके, दिस इज टिपिकल एब्सेंस. बट आफ्टर दिस सीजर पेशेंट इज नॉट हैविंग एनी कंफ्यूजन. पेशेंट को ऐसा लगता ही नहीं कुछ हुआ, पेशेंट को पता ही नहीं कुछ हुआ है करके. सो पोस्ट इक्टल कंफ्यूजन इज एब्सेंट. ओके, इट इज अ टिपिकल एब्सेंस सीजर. Next, which of the following is not seen in Parkinsonism? Now, what happening in Parkinsonism? There is decreased secretion of dopamine because of substantia nigra damage lesion. So now, whenever dopamine decreases, it will increase the tone. So when tone increases, it will cause rigidity. When rigidity is there, it is very difficult to do any action. Patient will have slow action, slow movements will be there. It is called as bradykinesia. Then characteristic feature of the Parkinsonism is static tremors. At rest, patient will have tremors. Hands will be moving like this. These are static tremors. Okay. Hemiparesis, it is not a feature of Parkinsonism. It is not a feature of Parkinsonism. Then, a 26-year-old male, known case of rheumatic heart disease with atrial fibrillation, presents with acute onset weakness of left side of body, which recovered completely in 18 hours. CT scan brain is normal. The most likely diagnosis is. So now, it can be an embolic stroke. But when will you say a stroke? What is the definition of stroke? What is stroke? Focal neurological deficit because of vascular cause. Okay, so I may think it may be a case of atrial fibrillation, atrium is not pumping, so thrombus is formed in atria. Thrombus is transferred to left ventricle, and this thrombus or small embolus is transferred to left ventricle to then to aorta, then embolus entered in brain, and it is causing paralysis. Yes, it is possible. Thrombotic stroke, not possible, because in thrombotic stroke patient will have gradually progressive weakness. It is sudden onset weakness. Transient ischemic attack. Now what is meaning of transient ischemic attack? If patient is having sudden onset focal neurological deficit, but this deficit, if it is recovered completely within 24 hours and brain imaging CT or MRI is normal, then it is called as transient ischemic attack. So it is nothing but a embolic stroke which recovered completely, and MRI CT is normal. It is called as transient ischemic attack. If out of these two things, if any one is absent, it is called as stroke. Otherwise, it is a case of transient ischemic attack. So the same question, if they ask me, recovery occurred after 24 hours, suppose recovery occurred in 25th hour, or if CT scan is showing a small infarct, answer will become stroke. But the same patient recovered completely within 24 hours, CT MRI is normal, answer is transient ischemic attack. All of the following are known predisposing factors for Alzheimer dementia, except, remember, smoking is protective for Alzheimer's dementia. Smoking is not risk factor for Alzheimer's dementia. Low education level, female gender, Down syndrome, then diabetes, then presence of ApoE4 gene. These factors increases the risk of Alzheimer's dementia. Smoking is protective for Alzheimer's dementia. Then a 50-year-old male coming with fever, headache, decreased level of consciousness. So it is suggestive of some infection of brain or meninges. On examination, neck stiffness is present. So a classical case of meningitis. CT scan, brain is normal. Routine investigations, HB normal, AST ALT normal. CSF analysis, WBCs are increased, neutrophils dominant. So when WBCs are increased, it is suggestive of infection present. Neutrophils dominant, suggestive of bacterial infection. Lymphocyte dominant, suggestive of TB. Proteins are increased. Normal proteins in CSF 20 to 40. Sugar 40 to 60. So proteins are increased, sugar is decreased. Sugar decreased, protein increase, suggestive of bacterial infection. So it is a bacterial meningitis. Why not viral? In viral, protein and sugars, they remain normal. In viral, lymphocytes become dominant. In fungal, neutrophil can be dominant, lymphocytes can be dominant. Both can occur, but more than 1000 WBCs, it occurs in bacterial infection. In fungal infection, WBCs increases up to 600. So answer is bacterial infection. All of the following are typical auscultatory findings in mitral stenosis, except, again except is there. In mitral stenosis, loud heart, first heart sound, loud S1, it is the classical feature, because in mitral stenosis, left atrial pressure is increased. And what will happen when left atrial pressure increases? It will push the mitral wall, it will go widely separated, and now because of decreased diameter of mitral wall, left ventricle is not completely filled. Normally what happens when blood enters from left atrium to left ventricle? When this wall is open, blood left ventricle fills, blood enters in left ventricle. When left ventricle is filling, blood will come below the cups of mitral wall, and mitral wall comes forward. And when left ventricle systole start, this mitral wall will close, and the distance between two cups is very less. In mitral stenosis, what is happening? Blood is entering in left ventricle, but left ventricle is not completely filled because diameter of mitral wall is decreased. So now blood is not coming below the cups. So mitral wall, it will remain away from each other. When left atrium contracts, wall, these cups, they will go away. Blood is not coming below the cups, so cups, they are not coming towards, they are not coming near to each other. So when left ventricle is contracting, cups are away from each other, and when cups, they are collapsing from a distance, they will produce a loud S1 sound. Opening snap. Why opening snap will occur? Now suppose this mitral wall is closed. The mitral wall is closed. Normally what happens when ventricular systole is there, wall is closed. When ventricular diastole starts, this wall will open like this. So normally wall open like this. Now what is happening in mitral stenosis? Walls are stenosed. It is very difficult to open the wall. So left atrial pressure will increase. When left atrial pressure is increasing, this pressure will cause pushing down of wall, bellowing down of wall. So wall will go down, and these cups, when they are going down, they will produce a opening snap. They will produce a opening snap like this. Okay, so this wall, now they are not opening like this. These walls, they will go like this, and then they will open like this. So this bellowing down of wall from this, it will give you opening snap. Mid diastolic murmur, blood flow from left atrium to left ventricle, it is occurring during diastole, so it will give mid diastolic murmur. Pansystolic murmur, it is a feature of mitral regurgitation. In mitral regurgitation, valve will open in opposite direction. When left ventricle contracts, blood will enter in left atrium throughout the systole. So it will give you pansystolic murmur. So pansystolic murmur, it is not a feature of mitral stenosis. Then, which of the following combination of cardiac condition and its murmur is wrong? Aortic regurgitation, it will give you early diastolic murmur because of reversal blood flow from aorta to left ventricle during early diastole. Mitral stenosis, mid diastolic murmur, yes, it is correct. Mitral regurgitation, pansystolic murmur, it is also correct. Ventricular septal defect, it is the defect between two ventricles. There is a connection between left ventricle and right ventricle. So when systole is there, throughout the systole, blood will travel from left ventricle to right ventricle, and pansystolic murmur can occur. But aortic regurgitation will not have pansystolic murmur. It may give you ejection systolic murmur, but it cannot give pansystolic murmur. And causative organism for rheumatic heart disease, that is for rheumatic fever, it is group A beta hemolytic streptococci. Antibodies are formed against this bacteria. These antibodies, they will attack on walls will be damaged. It will cause rheumatic heart disease. Then what is cor pulmonale? What is cor pulmonale? Patient is having disease in the lungs are damaged, and when lungs are damaged, lungs are not accepting the blood, then there will be increase in the pressure of pulmonary artery, and there will be increased pressure on right ventricle, and right ventricle will fail, and this failure is because of the lung disease. So when heart is failed because of the lung disease, it is called as cor pulmonale. Then, in bronchial asthma, glucocorticoids act as a potent bronchodilator? No, they will not act as a bronchodilator. They will reduce airway inflammation? Yes. Steroids, they inhibit our immune system, they decrease the inflammation. So B is the correct answer. They are not related with degranulation of mast cells. Block the action of humoral mediator? No, it is not the correct answer. Steroid preparation which can be given inhalation, very important MCQ. Dexamethasone, it is available oral tablet, it is available as injection, it is not inhaler. Triamcinolone, it is used in the skin diseases, is a topical steroid. Beclomethasone, it is available as an inhaler. Okay, fluticasone, it is available. Beclomethasone, it is available. Hydrocortisone, again, injection and oral tablets are there. So answer is C. Abnormal function of epithelial chloride channel is the cause of abnormal function of epithelial chloride channel. These channels, they are present in airways, pancreas, intestine, and if the channels are defective, patient will develop cystic fibrosis. Addison's disease is because of adrenal insufficiency. It is primary adrenal insufficiency. Marfan syndrome, it is defect in fibrillin gene. Diabetes insipidus, there is decrease in ADS secretion or kidneys are not responding to ADH. It is cystic fibrosis. Pleural effusion is typically lymphocytic in. Yes, again, lymphocytic fluid, it is a characteristic feature of TB. Okay. Anywhere in CSF or in pleural fluid, in ascitic fluid, if lymphocytes are increased, lymphocytes are dominant, think about TB. Tracheal shift to opposite side is seen in. Suppose if patient is having pleural effusion on left, it will push everything in the center towards right. It will apply the pressure and will push the things towards opposite side. So tracheal shift will occur to opposite side in pleural effusion or in pneumothorax or in hydropneumothorax. These things, pneumothorax, hydropneumothorax, pleural effusion, these things, they will push the mediastinum to opposite side. Consolidation is the pneumonia. It is the fluid in alveoli. It is not going to shift the mediastinum. Mediastinum will remain in the center. Fibrosis of lung, fibrosis will pull the mediastinum. It will pull toward the same side. Cavity, it is again not going to push or pull the mediastinum. It will remain in the center. Most common source of pulmonary embolism, most common, it is a large veins of legs. Deep vein thrombosis of legs, deep veins, they are the common source of pulmonary embolism. Thrombus present in the calf vein, if it is broken, it will give small embolus. Small embolus will enter in inferior vena cava, IVC. It will enter in heart, right atrium to right ventricle to pulmonary artery to lungs, and now it will block the vessel in lungs. Nephrotic syndrome is characterized by following manifestations, except is there. Proteinuria, yes, it is the diagnostic criteria. Proteinuria must be present. Hyperlipidemia, dyslipidemia occurs. Edema, anasarca occurs. Hypertension is not a feature of nephrotic syndrome. Hypertension is a feature of nephritic syndrome. Okay, so please remember these points. Nephrotic syndrome has anasarca, dyslipidemia, hypercoagulable state, proteinuria more than 3 gram per day. But remember, glomerular GFR is relatively spared as compared to nephritic syndrome. In nephritic syndrome, characteristic features are hematuria, hypertension, rapid decline in GFR. Proteinuria is present, but it is less than 3 gram per day. It is nephritic or nephritic syndrome. Then, polycystic kidney disease may have cysts in all of the following organs except. Remember, in polycystic kidney disease, it is adult onset or autosomal dominant polycystic kidney disease. Cysts can occur in any organ of the body except lung and brain. Cysts are not seen in lungs and brain in polycystic kidney disease. Best single laboratory diagnosis of best single lab aid or lab test in diagnosis of pulmonary TB. Skin test, no. Chest X-ray, it is a good test but not the best test. It will tell you pneumonia is present, infection is present, where it is present, but it will not tell you this infection is because of TB. Okay, sputum examination is the best test. Sputum gene expert, sputum AFB culture, sputum for AFB. These are the investigations available. Now we prefer sputum for gene expert. In this you will check the DNA by polymerase chain reaction of this TB bacteria, and you can also check the resistance for the drug rifampin. Okay, the sputum is the best test. In AIDS there is deficiency of which cell? AIDS HIV virus, it attacks on CD4 cells and patient will have CD4 deficiency. Okay, so CD4 cell deficiency occurs in AIDS. Deformity shown in the figure is seen in a very characteristic deformity shown. Patient is having hyperextension of proximal interphalangeal joint and flexion at distal interphalangeal joint. This deformity is called as swan neck deformity. It is the characteristic feature of rheumatoid arthritis. It is the characteristic feature of rheumatoid arthritis. See this. Okay, swan neck deformity, flexion of DIP, extension at PIP. Now opposite can also occur. Opposite is flexion at PIP and extension at DIP. It is called as Butner's deformity. Okay, so both are seen in rheumatoid arthritis. So answer is rheumatoid arthritis. In gout, what is happening? Lower limb joint first two is commonly affected. In osteoarthritis, which joints are affected? In osteoarthritis, knees are commonly affected, or you can say weight bearing joints are commonly affected. In rheumatic fever, patient will have migratory polyarthritis, means one joint will be affected, swelling pain will occur, then it will become normal, then other joint will be affected. It is a characteristic feature of rheumatic fever. So correct answer is rheumatoid arthritis. Okay, so we have completed the most important MCQs of medicine for your exam. If you have any doubt, in medicine, you can WhatsApp me. So I will give you my WhatsApp number. My name is Dr. Rahul Nikumbhe. If you have any doubt in any part of medicine, you can message me on 9577010313. Okay, so dear students, all the best for your exam. Give your best. If you have any doubt, you can message me anytime. Okay, so all the best. Thank you for your patience, and welcome for all doubts. So I am stopping now.